Good afternoon. My name is Jordan, and today Joshua, Jessica, Jolly, and I will be explaining the effects of bulimia nervosa can have on an individual. For the majority of you, learning about your patient's or client's eating habits is something that is almost unheard of. However, some behaviours can cause major disruption in their day to day life. For people living with bulimia nervosa, rituals such as forced binge eating and purging is a regular occurrence. By looking at how someone is diagnosed with bulimia nervosa according to the DSM-5, then investigating the etiology, early signs, epidemiology, treatment methods, and recovery strategies used, not only will one have a greater understanding of this condition, but also know what help the patient requires. The DSM-5 has a specific criteria for diagnosing someone with bulimia nervosa. Firstly, there must be recurrent episodes of binge eating, which can be categorized as either eating substantially large amounts of food in less than a 2 hour window, or a lack of control during the binge eating episodes. Secondly, recurrent extreme acts to prevent weight gain, such as self induced vomiting and misuse of drugs such as laxatives or diuretics. These behaviours must be apparent at least one time per week for 3 months for the individual to be classed as someone with bulimia nervosa. I will now pass you over to my associate Jessica, who will discuss the causes and factors associated with bulimia.
Thanks, Jordan. As far as the etiology goes for this psychiatric illness, surprisingly, there are only three major categories that correlate with the occurrence of bulimia. It is a mix of biological, psychological, and environmental factors. To start with, the genetic component has a major role in a lot of bulimia cases, as studies have found it in twins and adoption scenarios. To be exact, more than 50% of the risk of developing an eating disorder is based on your genetics. Despite these statistics, individuals known to have a family history of this disorder do not all develop it. In addition, many researchers have also emphasized the environmental influence of mass media and cultural norms that equate beauty and thinness. Majority of these beauty standards are directed towards women, which is why a vast number of teens and young adults that suffer with bulimia are in fact females. This perception of needing this body figure creates low self-esteem issues, thus linking to the psychological factor. For many individuals who have struggled with an eating disorder, low self-esteem goes hand in hand with these mental illnesses, therefore adding another causation of bulimia. I'll pass it over to Jolie for her to explain the treatments available.
Thank you, Jessica. Individuals who associate themselves with bulimia tend to exhibit apparent signs. This includes unusual behavior during meals, fear of gaining weight, mood swings, and eating large sums of food which is then compensated by either purging or laxative abuse. These are regarding the psychological signs. However, physical signs are more apparent later when the routine is constant. Dental issues and scars on fingers such as calluses and blisters are more prevalent due to repeated purging. Alongside with dehydration, weakness, and social withdrawal, it is assumed that bulimia nervosa revolves mainly in purging or forced excretion. However, there are certain aspects where the individual resides to exercising, also known as exercise bulimia. Rather than self-induced vomiting the food intake, excessive exercise occurs to lose weight gain. Individuals who suffer from bulimia nervosa tend to have a fear of weight gain. Therefore, through either purging or overexercising, it is a compensating behavior to get rid of their guilt. DSM-5 have categorized on how often a female with bulimia engages themselves into compensating behaviors per week. The category ranges from mild to extreme, where mild has an average of 1 to 3 episodes, moderate has an average of 4 to 7 episodes, severe with an average of 13 episodes, and extreme with an average of 14 episodes. Ever since 1980 and early 1990s, there had been a rapid incline of bulimic patients. National Eating Disorders, or also known as NEDA, over time have accumulated significant data on the prevalence of eating disorders. When a research has been conducted on 496 young females, it has been indicated that at least 5.2% have associated themselves in eating disorder routine assessed by the DSM-5 criteria. The disorder can occur to anyone individually as stated there. Lifetime prevalence of bulimia nervosa is estimated to be around 1.21% for men and 2.59% for women. Countries with the highest rate of eating disorder revolves mainly in Asian countries such as Japan, the most prevalent, followed by Hong Kong, Singapore, Taiwan, South Korea, and so forth. Nonetheless, 16% of the Australian population is said to be affected by eating disorders. However, 1% in general is said to be bulimic and anorexic. As mentioned before by Jessica, there are three main factors as to how bulimia can come about: psychological, environmental, and biological. In doing so, by analyzing these three factors, treatments can be provided for those who are bulimic. Henceforth, I will hand it over back to Jordan to discuss the treatments available.
Treatments for bulimia range from mild, natural approaches to more intense, both medicated and monitored responses. Preferred methods come from educating the individual around basic nutrition requirements. This is done by teaching them how to structure meals, along with learning about calorie intake in relation to body weight. Cognitive behavioural therapy, or CBT, has been shown to be the most effective therapy for people experiencing bulimia. The approach helps to identify and transform negative thoughts about themselves and food, then teaching techniques to cope with eating food on a regular basis. Family-based treatments is another popular method. This is because parents or loved ones can intervene around the individual's poor eating behaviours and help them to regain some control. The final psychotherapy used is interpersonal psychotherapy. This can help uncover difficulties in close relationships and improve communication skills around what may be the cause or when they need help. If these methods are unsuccessful, antidepressants like fluoxetine has been shown in some studies to reduce binging sessions up to 67% and have a 56% reduction in purging frequency. For more extreme cases, or when someone is in a life-threatening position, hospitalisation is an option. However, for more mild cases, hospitals may offer day treatments or programs to help the individual break the cycle. While treatments can offer a short-term fix, the recovery for the patient is paramount for their success. For this, Joshua will elaborate on avenues that have had positive results.
Thank you, Jordan. The path to recovery of bulimia nervosa starts and ends with the individual, the wounded self. It is an intensely personal journey for the affected individual. The path to long-term recovery is not a linear process. For the affected individual, it is about finding the courage to break out of the cycle of addictive coping strategies and developing healthy long-term habits. It requires self-reflection and an understanding of the illness. Eating disorders develop as a coping strategy for managing emotional triggers. The affected individuals are skilled at using eating to manipulate their emotional states. However, this results in the redirecting of these emotions onto oneself and body. The affected individuals then purge themselves of the calories. The typical result is feeling of relief, but that is often accompanied by depression and a sense of being out of control. Similarities have been found between bulimia nervosa and drug addiction in their underlying neurobiological pathways. Therefore, applying addiction-focused treatment may reduce the high rate of relapse. However, removing addictive drugs from a drug addict's environment seems plausible, whereas food is necessary for life. The affected person must develop healthy new habits and cognitive pathways to deal with cravings. Cognitive behavioral therapy, coupled with medication, may be useful for developing these assertive and regulated positive habits, giving back a sense of control over the affected person's eating and subsequent perceived need for binging. Longitudinal follow-up studies find that the long-term prognosis for bulimia nervosa is substantially better than anorexia nervosa, but that is somewhere between 30 and 50%, with eating disorders continuing to have problems 5 to 10 years after seeking initial treatment. I will now pass you on to Jolly to conclude our research.
To conclude, bulimia nervosa falls into the category of eating disorders, which is a psychiatric illness. It divides the patient into a constant routine in which allows them to gain weight and lose weight in a short amount of time. Case studies have been conducted to analyze the effects of bulimia in an individual. My associates and I have covered the basis of the illness itself. Bulimia is segmented into three main categories as to how a patient can be bulimic: psychological, biological, and environmental. Under the DSM-5 criteria, any individuals can suffer from bulimia nervosa once a constant routine of binge eating and compensating behavior occur at least one time per week for at least 3 months. Signs are then more apparent as the routine prolongs, such as scars and calluses in fingers, dental issues, and mood swings. Nonetheless, treatments are available to those who are bulimic, such as educating on nutrients, cognitive behavior therapy, family-based treatments, and antidepressants. Alongside with these treatments, the patient themselves needs to be adaptable to the changes of their addictive cycle as a path for their recovery. Thank you for listening. It has been a pleasure for Jordan, Jessica, Joshua, and I to be presenting this report.